gotten quite a bit of
Joan
feedback.
Bartok, can you give me a call when you get a chance? Just want to touch base with you on
Sorry,
this
if you're
technology piece. Thanks.
sorry, Joan.
Oh, that's
I'm
okay.
I'm gonna try to mute everybody else and just leave you on, okay?
Okay.
Give me just a second.
Okay.
And that'll make it easier. All right, try that now, Joan.
Okay. We have received quite a bit of feedback. We're looking at the feedback, sort of bucketing it, because a lot of the questions or the comments that have come in are similar, but we have not reviewed it in entirety. So I told David on another call we would talk about the feedback because we need to sit down and really look at things. We are on currently version 17 of the draft telehealth regulations. So, you know, over the course of time, we have made quite a few changes to it based on comments that came in earlier. And we probably will be making more changes, and it will be, you know, version 50 by the time we're done. A lot of people do have comments. Our next step, once we review the feedback, make changes that we feel are necessary, we're going to submit the package to our Division of Legal Affairs. Once it comes back from them with any changes that they will be making, it will be posted in the state register for public comment. We will then again be responding to comments, but we feel that we think we'll get less comments because we've shared it widely at the present time, and we're looking at those comments, many comments now. But we will be making changes based on anything that might come in that we haven't already reviewed. When the regs are finalized, we will be publishing a Medicaid update article, and that's going to outline the policy and the billing guidance. Currently, just to go back a little, the actual draft regulation has 3 applications of telemedicine, which I'm sure everyone is familiar with, of telehealth: telemedicine, store and forward, and remote patient monitoring. Telemedicine, Medicaid currently reimburses for that. The list of practitioners in the legislation has been expanded, and that is currently being done and being reimbursed. Store and forward and remote patient monitoring are applications that we currently don't cover. We have state plan amendments that we submitted, and we're waiting for CMS to get back to us with approval. So at the present time, both of those applications can't be billed for. Or you can do them, but you won't be reimbursed for, you know, providing those services. And I think we also have changes to 533.6, which is the radiology, the regulations surrounding radiology. And we have changed the regulations so that teleradiology, the radiologist who performs the service, will be reimbursed a professional fee. Currently, the way the regulations read, it doesn't really allow for that. Hospitals can provide radiology services via teleradiology, but they have to make sure that the regulations are met the way they currently read. It's invisible to us if they use a teleradiologist, and they would pay the teleradiologist out of the global fee that they receive. We're now making changes so that that can be separated and the teleradiologist can be reimbursed individually. We just, some of the requirements for that are that the teleradiologist, regardless of where they are licensed in New York State, enrolled in New York State Medicaid, credentialed and privileged at the facility where they're doing the reads, that they're in one of the 50 United States. We are not paying anyone out of the country, and we're only paying for the final read. We're not paying for the initial or the wet read in addition to the final read. There's one payment that will be made. And I think that sort of covers the teleradiology draft regulations. And that's the update.
Okay.
Any questions?
Joan, I have a question kind of off right at the beginning. So in a similar way, to radiology. I'm wondering about store and forward for ophthalmologists. Is that?
We in the draft regulations, we are starting out limiting store and forward to dermatology and ophthalmology. But we have put in a statement that says, and other specialties as determined by the commissioner, so that we can expand it as time goes on. But this is new, so we're starting out with just the two specialties. Ophthalmology, the ophthalmologist who does the reading of the pictures that are sent to him or her will be reimbursed. And I think that we're still determining a code to be used, a CPT code, and we're going to pay a percentage of what we normally pay for that code. That's what we're looking at the current time.
Okay, so not the current full reimbursement.
No, not yet. I'm on a webinar. Alrighty. Okay.
Did you hear that, Joan?
I'm sorry. I was hearing two people talking.
Yeah. So so you're talking about some reduced amount of reimbursement then?
That is right now what's on the table. It hasn't been completely decided, but it depends on the code. We were looking at the evaluation and management codes, which are timed codes, and we were looking at paying a percentage of what we pay for those codes currently for the to the practitioner who's reading the image that's been stored and forwarded to them. But the more we look at this, there's face-to-face requirements, and we don't think we can use those codes because of that. So now we're looking to see if there might be another CPT or HCPCS code that would lend itself better to the store and forward application. We are going to require that the GQ modifier, which is for asynchronous transmission, be put onto whatever code we select. But again, that'll be down the road, and that will be in the Medicaid update that we publish when everything is finalized. We'll instruct providers on how they should be billing for these various applications.
Okay, got it. All right, I think the lines are mostly unmuted at this point, so if you want to raise your hand, I can try to call on you. So underneath the attendees section, you'll see a little part that says raise your hand. Do you see that? Questions for Joan? Or if you want to just try to shout it all at once, that would be fine too.
Do you have a target date for the Medicaid publication?
No, we don't. We're sharing internally, and it has to go through the process that I just explained. And, so it still has to go over to legal, come back to us from legal, and then go out for, I think it's 45 days that it gets published in the state register. And then, and then all of those comments have to be responded to before it's finalized.
Thank you.
Sure.
Averill George, I think you should be able to go ahead and ask your question.
Hi, my question is the same question I've been asking forever now, concerning the physician location. Is that going to be changed?
Is that going to be changed, did you say?
Yeah.
No, not at this time. The location of the practitioner providing the service for telemedicine remains, in a regulated setting.
Repeat that for me. So the physician does not have to be in an Article 28 facility.
They can be in their office, and if their office is in the home, then if that's where they provide patient care out of a home office, then that would be fine. But if it's just in their home, no, at this time, it remains either an office or an Article 28 or, a regulated facility.
So for example, the email that I sent you, where I have an office with a workstation and it's physically located on one of the floors of my home, would that be acceptable or no?
Do you see patients there?
No, no patient physically is seen there.
No, then that's not acceptable. There's no way that that can be regulated. And so if you were to have an office in a facility, then that would be acceptable. And that's not to say this isn't subject to change down the road, but at this time, that is the way that the regulation is being written.
Do you understand that that is kind of like a penalty that you're giving then to telemedicine physicians? You're penalizing physicians that see patients over that medium. There is regulation. What appearance that you have, there is regulation in place to protect. So I don't understand how that should be part of this new regulation revision that you're doing.
I think that the thoughts on it, and like I said, this is subject to change, but that it's not for the convenience of a practitioner. It's more for accessibility for patients who are unable to get the particular type of care in the area where they're located. And so in order to access that care, telemedicine is the vehicle allowing that. It's not, we don't feel that it's to convenience practitioners so that they can stay in their home and do this at this time. Let me say that. This could change. It very well could change. So I'm just communicating to you where we're at right now. And like I said, it's a possibility that it may change.
So the hospitals that I'm servicing are hundreds of miles away from me. Does it matter?
Exactly.
It doesn't matter. If I'm in a facility, so now as a physician, I have to pay rent to try to rent out a space in someone else's clinic to see patients that are hundreds of miles away from me that will never physically interact with me. So that, you really need to think that over, because that's overregulation. And
I do think that is what telemedicine, the patients are at a distance from the practitioner.
Yeah, I think what April is saying there, Joan, and she works in infectious disease.
Uh-huh.
But, things like when we need access to a specialist.
Yeah.
So if there's a shortage, let's say in psychiatry, which there is, sometimes the only providers that we could tap into would be the type of provider who's working from home. And so it becomes an access to care issue. It seems like it's not just convenience,
there are issues with credentialing and privileging, and accepting the credentialing and privileging of the distant site hospital. If there is no distant site facility, I don't know who would be doing the credentialing and privileging of that practitioner. There's a lot of things that play into it, and that's why I'm saying for now, there's a lot that we are looking at and discussing, but we also want to make sure that, that the care that's delivered is quality care, and that, we want confidentiality maintained. There's many things, and nothing, and that's why I say this is not set in stone. It could change, but right now, Dr. George asked, if we were going to change it at this moment. It's not being changed. Yep. Could it be changed in the future? Absolutely. I don't know. But we are reviewing all of the comments coming in, and decisions are being made and changes are being made. So let me say that
have not presented a good reason why the physician location counts. If the patient is 200 miles away from me, I am never physically going to be interacting with that patient. Me renting out space from another physician's clinic just to have an office in the building where I am not even seeing any of those patients that the other physician is seeing is a penalty. And that is what it is. It's a penalty towards practitioners, it's to independent practitioners or to physicians that decide they want to have their own tele-ID or telemedicine-based practice. It's overreach. It's absolute overreach. It's overregulation. If the concern is patient privacy, HIPAA already has penalties for physicians that do not respect patient privacy. We don't need to create more rules where in an area where people don't even have any. In these places where they have zero infectious disease practitioners, one of the hospitals I just signed up with, they haven't had an ID doctor in the last 15 years. 15 years. People died because they live in the wrong zip codes. And by creating regulations like this and saying, well, not right now because we don't really understand. You don't understand, but people who actually see patients speak to physicians and see what they have to say. Speak to physicians before we make rules concerning physicians.
Well, let me. I can only tell you that this is the way it is currently. I'm just responding to your question, Dr. George. It is something that we can look at. You can see, I mean, we're talking about Medicaid. Now, do other insurers follow the same policy? Blue Cross and other private commercial insurers? Probably not. So you may be able to see, but for the Medicaid population at this time, this is the way the regulation reads, and it is draft. Okay, which I just said before, it's draft.
Let's move on to some other questions, James, if I can.
Sure.
I got Brenda Bartok. You should be able to ask your question, Brenda.
Yes, thank you. I really have to add on to what the previous physician was saying because we're being asked in our region in Rochester, New York, there's a large rural region around us. These small critical access and community hospitals cannot afford, cannot attract specialty physicians. We're being asked to provide telestroke services and NICU subspecialty services at these places. Our physicians in Rochester are working triple time trying to keep up with the volume just in our own region, and to support these people, they cannot be expected to go in 24 hours a day, 7 days a week, have coverage to be able to bill for these services by Medicaid. We need to be able to allow our physicians to have a little bit of life and still yet respond to urgent, critical needs when a hospital in the region has those. So I just want to add that also to the doctor talking about infectious disease. This is really, you're talking about how do you provide care that gives the patient, the Medicaid patient, the access. We need to also be concerned about unnecessary expense being added to have some kind of expensive on-call coverage 24/7 to be able to bill Medicaid when the need comes up versus having doctors willing to take it at any point, anywhere, when they're needed.
Yep. How about a question from Dawn?
Thank you.
Dawn?
Yes, my question is in reference to a comment that was made earlier. Again, it goes back to a location comment when Joan was talking about teleradiology and that it could, reimbursement would only be for a provider that was within the United States, no out of country. Will that also hold true for telepsychiatry, that they would need to be, within the 50 states?
I don't think we really. I don't know. I would say I think so, but I don't think that's come up before. That's an interesting question. Are you thinking of using psychiatrists out of the country?
Well, we had a provider here at our facility several years ago who is interested in doing telepsych. She's New York State licensed, credentialed for it. She was credentialed and privileged. However, she has moved to France, but she still would like to have a continue a relationship with us in via telepsychiatry. So we we're looking at options, to get our program up and running, and that was something that we put on our table. So I didn't know if that.
We can, I can look into it and we can get back to you on that if you want to send that question in. That's a good question. I can't answer it now because I really don't know, but it's something that can be considered. We can discuss.
And who would I send that question to? Who would I send that to?
You can go ahead and send it to me, and I can forward it on if you like.
Perfect. Okay. Thank you, David.
Great. Thank you.
Yeah, we had a similar case to that, Joan, in Watertown, where we have a locum that was working in one of the hospitals. He actually comes to the States and, goes back. He comes here in the wintertime. And then he goes back to Barcelona. Like, why? Why do you do that? But he'd love to be able to provide care from Barcelona.
Okay. And he is he a telepsychiatrist?
He is, yeah.
Okay.
Iris Berman.
Yeah, I want to just say two comments. One goes, I don't want to make it an argument because I understand there's things that have to be verified, but just two things to consider, and I believe we wrote this in our response as well. But one is it's the Medicaid population that needs the most help. They're the most at risk. And it doesn't matter whether you're rural or in the city, they are the people that can't get care. And by limiting the ability to get to a provider who is already stretched to the max, and perhaps even running to 2 or 3 different hospitals, you are not just penalizing the physician, you're penalizing the patient. So I just want to make that very clear. If you can take that message back, I'd appreciate it. The other argument to that is within the health system, if we have somebody who's privileged and credentialed within our health system, and we set them up at home with a monitoring system that has a dedicated modem that keeps them behind our firewall, that should be considered an extension of Article 28.
Okay. That's interesting. Yes, I'll take that back too, with a dedicated modem. Okay. And they've been credentialed and privileged.
We're always credentialed at the facility because you're providing services for the hospital. All the hospitals credential you.
Correct. So the only issue, if you're really that concerned, is about security. If they have a dedicated modem, which is an outreach of the hospital they're affiliated with, then they're secure. Because Article 28 requires them to be secure as long as it's done properly.
Well, again, we can take a look at it.
It's just another angle that you should be thinking about.
Okay, we will definitely look at it, and I'm taking notes, so I'm bringing everything back. So this is helpful.
I'll also be providing a link to the recording of today's call too.
Oh, good. Okay.
So you get that too.
Good.
Will
That's
Irwin,
great.
I think Will, are you on the line?
Who is that?
Will Irwin? Can you? Actually, I don't even see him. Oh, I guess maybe he dropped out. Other questions for Joan? You thought this was going to be short, didn't you?
I did.
Hello, can you hear me?
Yes.
I can, yes.
Okay, I sort of raised my hand, but it didn't work. My name's Lowell Feldman. I'm with the Lowell Group Consultants. I've been in long-term care for about 40 years in New York. In regards to nursing homes in particular and assisted living, if a physician's credentialed as part of the physician group caring for the residents in the skilled nursing home, and for an after-hours call, if the physician's at home on his laptop or smartphone, of course our telemed systems are all password protected and meet HIPAA regulations, would that be reimbursable? Is that office criteria going to have the same situation? Because with the district of preventing rehospitalizations, the number of hospitalizations that occur after hours and urgent calls for physicians who really can't assess without telemedicine in these facilities is the goal of district, and having them have to sit and wait in their office around the clock rather than be out of the restaurant or in their own private environment in their home to accept these calls defeats the purpose of preventing the rehospitalizations certainly weekends, after hours, and for other situations. So has that been addressed in draft regulations as of yet?
I think that the draft regulations basically just say that that they exactly what we've been talking about. The provider needs to be located in a regulated setting or an office, and so that would apply across the board to all telemedicine that is being provided. And again, like I said, I will take this back and we will look at it. But it's pretty much the same thing. It doesn't change. It's unchanged at this point, the way it's written.
Yeah, I'd have to agree with others that it's presenting a huge obstacle in rendering care for everybody in multiple zip codes, and not even from skilled nursing, the assisted living arena, or federally qualified healthcare centers for home care and chronic monitoring situations, and also in the behavioral health arena for another question I had there, community centers. I sit on the board of New Horizons Counseling Center, and we're restricted to catchment areas. Yet there's such huge underserved populations in rural areas around the state. I wonder if there's going to be any relinquishing of catchment areas for qualified and certified community health, mental health providers to go beyond the scope of the areas that they're servicing and provide services outside that area as well. Because certainly there is need in that area, and in the area of substance abuse and chemical dependency counseling and home monitoring. And it's not always during business hours. The push to deregulate some of it, and as long as the physicians are credentialed and qualified and meet the other criteria and that the HIPAA regulations are being adhered to, that they be able to accept calls and teleconferencing and telemedicine situations outside of a fixed physician office, which is the concept for telemedicine, not to have to make an quote unquote office visit.
Okay.
There's a question for Joan. Melissa Stotts.
Hello?
Melissa? Oh, she just took her hand down, I guess.
Okay.
Andrew Solomon.
Thank you, David. Joan, this is Andrew from the Northeast Telehealth Resource Center. I just wanted to mention, as you explore some of these issues that folks are raising, if it would be helpful, I don't know that any one state really has a perfect Medicaid policy, as most would consider it, but more than happy to help compile some of what other states in the region and the country are doing related to location requirements for the providers or other issues.
Okay, if you could get in touch with David, and then if you send me Andrew's contact information, or you give him mine, he can send me an email. That would be great.
Yeah,
Thank
great.
you. Thank you, Andrew.
Absolutely.
Thanks again. Other questions? Well, listen, I think we've beaten Joan up enough for now.
Oh. No, I have lots of information, and I really will. I will take it back. We will discuss it. We will talk about, I hear like a running theme that the location of the practitioner seeing the patient is, people are concerned about that. People would like practitioners to be able to provide telemedicine from a dedicated setting within their home, and I will take that back and make sure that everyone here is aware of that, and that they understand that that this is something that that many people feel would be beneficial, not only to to both the patient and the physician or practitioner. Okay?
Very good, Joan. Thanks for your help today.
Okay, sure. You're very welcome. Take care. Bye-bye.
Thanks, Joan. Bye-bye now.
Bye.
I see that Linda Roberts is on the line from OMH. And Linda, I don't know if you have any updates on the OMH regulations.
I know that at this point in time, we did receive a target date, I believe we were thinking around September 1st time frame. We still have to go through and establish the details pertaining to the process from the BIC team. So that's the information that I currently have.
Okay. So you received some feedback on the proposed regulations?
I haven't personally myself, but I know that there has been feedback that was received, and the last information I had jotted down is I was thinking that we would have the new regulations around September 1st and work through, the process associated with that. But I haven't really personally been involved in it with myself. But we will be working very closely to make the appropriate updates, because we have to update the standard guidance document as well. So whatever changes come about, we're going to need to formulate a group, a committee to get together and make the appropriate modifications to our telepsych, to the standard guidance document.
Okay. So the next steps there are then to form this committee and start working on that, huh?
Yes. So at this point, I'm just waiting to hear back on when we will be able to move forward on that. I know Amy Smith, who has joined in the past, is one of the key participants, and Sharon Kruger, and they're working on the Bureau and the Bureau inspection certification process. So that is something that they're going to be working on, and then we'll also be working with them. Chris Rambo, the project manager, and myself will be making modifications, and that's where it stands right now.
All right.
So we can keep you informed as to our progress, but at this point in time, we're just waiting till, we get the information back on that.
Very good. Thank you, Linda.
You're welcome.
Any other questions for Linda? All right. We were going to have Mary Beth McCall on again from Excelis, but she's actually on vacation, and as it turns out, she's going to be retiring soon. So we'll have to find out who is taking her place and try to coordinate with whoever that is. But Mary Beth has been a tremendous champion for telemedicine, and we're going to miss her. We're going to miss her a lot. So as we kind of close out today's call, I wanted to bring up this issue of the direct-to-care model because it's something that we see on the horizon. It's something that's becoming, more and more of an issue. If you look under your handout section in the GoToWebinar, you'll see that I put a document there, and I'll send this out via email as well. But under the handout section, it's a document called Direct to Consumer Trends in New York Telehealth. This is a document I put together several months ago for our medical management committee, just to kind of give them a heads up about what's happening. And so I guess the conversation I wanted to have around this idea, I know that there are some providers on the line today who are working on this direct-to-care model. In Albany alone, we know that there's 3 new companies that have launched their direct-to-care models. And this learning collaborative is a great opportunity to, think about how our hospitals, primary care settings might take advantage of the direct-to-care model, but also, are there things that we would want to encourage medical boards, the Department of Health, OMH, to consider as guidelines or some kind of roadmap for direct-to-care in New York. So I'm going to just kind of open that conversation up, and as you look at the document I prepared, you can see that this is a little bit old, but see, August of 2014, the Deloitte study calculated there would be 75 million virtual visits in North America. Potential exists for as many 300 million visits a year. So it's pretty large. When we think about New York, you can consider things like Walgreens and Kinney Drugs, these folks who are moving into that space. So our new competition becomes companies like Doctors on Demand or American Well. And there exists the opportunity for us not to see them as competition necessarily, but as a platform to provide care. All right, so have at it. Let me hear your thoughts. Or maybe you haven't thought about this yet.
Dave, can you hear me?
Yes, we can.
Hi, this is Sarah Bollinger. I've been active in the workplace wellness movement, and this is very popular with the employer benefit type concepts where instead of letting a person take a half a day off, that they just call up the doctor right there and see if the person's really ill enough or get a prescription or something without leaving the workplace, and is being seen as a real benefit because it's less hassle for the patient and the employer, and it's less coverage issues, and you kind of determine whether there really is a need for something serious or not, as opposed to sitting around at urgent care for half a day. It's really kind of replacing urgent care. It does jeopardize, I think, the concept of a medical home and having, your own family doctor that knows you and knows your background. I think that's the downside of it. I think it's really being used similar to an urgent care.
So around that, Sarah, one of the things we might, say to DOH or medical boards, that kind of thing, is to say, maybe there should be some kind of requirement for companies that are doing direct-to-care models that they have contact with a primary care physician.
Some kind of copying in on the results of the visit would seem to coordinate the medical home idea. Now, these are not Medicaid recipients. These would generally be people, in private insurance plans. But I still think there's the whole thing around having the medical home is kind of undermined by patients just wandering off to any care provider that they come across.
Yep.
And a lot of times these are minor issues, which may or may, be nothing. So I can see the point of, just call up and have the person look at your rash and see if it's important, versus hanging around in a waiting room somewhere.
Other thoughts? Go ahead. I thought I might have heard somebody wanting to say something there. Okay. Do you think that there's enough interest in talking about this a little bit further in future learning collaboratives, or is this before its time? Maybe I can take a poll. I'm not very good at creating one, but
Well, this is Brenda Bartok.
Hey, Brenda.
Hi. One of the things I think that that there's still really lack of clarity around are what kinds of conditions really are most appropriate for these kinds of urgent care type of visits, when the patient could be calling in from the soccer field, home, work, wherever, and you have no peripheral equipment to use. I think having some guidelines around what things are appropriate to be managed without any kind of versus not would be helpful.
Yeah. You see in the document that I sent out there, at the very end of the document, there's kind of a list of the leading reasons for direct-to-consumer visits used by children and adults. So that'll give you a kind of an idea of, where the activity is. You'll notice on there there's kind of all others, which accounts for 20% of all the visits. Which, yeah, there needs to be some clarity around that maybe. Do we have anybody on the line from that's doing a direct-to-care model? Well, I'm sorry, Cory Zeigler. Cory, your hand has been raised forever here. Go ahead.
Oh, there. I was typing. Yeah, the one thing I wanted to point out to be thoughtful about it, and it just kind of goes with the comments of, circumventing the primary care, is how can we collaborate with primary care, meaning that, we think about things like hotspotting. I mean, if these are the things that patients will gravitate to, and how do we take advantage of that care setting to navigate them to the primary care or to needed screening. So if they're there, if we can figure out some way to include these direct providers in looking up the HIE or giving them some access to a population health management platform that says, oh, by the way, you also are due or potential risk for this, and that, and you need to follow up with your primary care and pull them into the clinically integrated network that way, because I think we're missing a lot of these patients completely right now, because that's not being done, and so could we take advantage of that, and how do we incentivize that? So maybe there's an additional incentive payment for some of these direct providers if a referral takes place or something like that back to the primary care.
It's a great idea. Terry Yonker. Terry.
Hi. Yes, I know when I was researching this way back when, maybe a year or so ago, I ran into something that said that the medical societies of each state needed to define this practice in terms of the doctor-patient relationship. And as far as I knew, the one in New York State had not accepted these kind of visits because they did not have the doctor-patient relationship established. I don't know if anybody knows if anything's changed on that.
Well, I know, Terry, that there are active models in the state, so they must be doing it. And I can think of one that pops into my head right away is Upstate Concierge. So they're providing direct to care from Albany, and they, like Sarah mentioned, they work primarily with employers. So unless they're doing it, inappropriately, yeah, I'd be surprised if they were.
Can anybody contact the medical society just to find out what their definitions are and regulations are?
Hey, David, this is Latoya from ATA. Can you hear me?
Yeah, we can, Latoya. Great to have
you. Hey
you.
there. So, I'm doing well. How about yourself?
Doing well. Glad you're there.
Thanks. So I just wanted to chime in a little bit. The Medical Society is actually the lobbying arm of the medical board, and the New York State Medical Board itself has actually come out with a pretty pro-telehealth position that's on their website. And I know that we cite it in the reports that we've done on physician standards of practice and licensure. They cover the fact that they recognize telemedicine as an appropriate way of establishing the physician-patient relationship, and they're one of many states that have decided not to get in the way of physicians being able to use this tool at their discretion to appropriately diagnose and treat their patients. And there's a link to that statement in our report, which is freely downloadable, but I'm more than happy to send that link to you, David, so you can share it with everyone. But the New York State Medical Board is very much pro-telehealth.
That's great. Thanks for helping us out there. Yeah, and if you could send that link, I'll forward it on to everyone.
Sure.
Lowell Feldman.
Oh, that's fine. So I'm just going to
Lowell?
them back right now. Are you going to be working?
Are you still there, Lowell? Maybe not. Okay.
Oh, no, I'm still here. It just takes a while to return to call and unmute. Yeah, well, I did ask a question to the department, and I don't know if Will Erling's on or not, but I've been working with him as well. But a lot has to do with utilization. I have 40 years in skilled nursing and assisted living and home care arena, and the focus is again to reduce hospitalizations. And these days, nursing home patients, if you're sending them out for outside, not only urgent episodic events, and a lot of those are behaviors as well, but the biggest rehospitalizations are COPD, sepsis, and then the behaviors. And between telemedicine and on-site point of service laboratory services, it can eliminate that. Yet the current regulations, as they're being proposed, are not allowing physicians, to participate unless they're sitting in their office, which is, in my opinion, absurdity. That being said, also a lot has to be done in the behavioral health arena and chemical dependency and home care monitoring as residents as well. A patient's home is not an office, and the doctor's certainly not going to be sitting around the clock in his office waiting to get calls from people outside these environments. I think there has to be a major effort to amend these new proposed guidelines and restrictions on the location of the physician, especially with all the bells and whistles that technology has, and provided they're HIPAA compliant, whether through separate distinct modems or just password protections and the various levels of confidentiality that are built into numerous of these telemed applications. So certainly, I don't know. I know I'm hearing that there's a Northeast Telemed Coalition. The one we're on this chat room now. Thank you is new to me. Actually, Will Irwin turned me on to it, and I'm consulting with them now, and also working with about 6 telemedicine companies. Wanting to provide service in New York. But again, when you come to the providers, both the institutions and the physicians, money becomes an issue. So I think we really have to go with what the parity law stated that was passed this year, that it be equal reimbursement to a live visit and forego a lot of the regulations. So that's my statement for today, and hopefully be able to with you.
Well,
I know I work with LaFoy and ATA. I'm an ATA member as well, and hoping to see New York really embrace telemedicine and not try to provide obstacles to improve the performance in healthcare. And what other people have said, whether it be rural or urban, the access is extremely limited. Try to get psychiatrists in the Bronx to come into a nursing home these days is virtually impossible. But with telemedicine, they're all willing, but they do want to get paid. They have a lot of medical bills to pay off from med school and years of training, and they'd like an income stream. So.
Yep. Thank you, Lowell. You'll want to maybe check out some of our earlier broadcasts, kind of as we talked about the parity law and the difference between coverage parity and payment parity. As we talk about direct-to-care models, it appears that most of them are, operating outside of insurance claims. Usually it sounds like it's put your credit card information in, and it's consumer paying directly. Now we know that Excellus, for example, up here in the North Country, they are reimbursing for direct-to-care models as well.
Yes, and I'm familiar with one group out on Long Island where PPS is actually providing payment to a telemedicine provider with a monthly per insured life amount for annual preventative visits, as well as urgent call and necessary visits. So some of the PPSs, taking it on their own, the insurers, to approve, because they realize the effectiveness in cost reductions of preventative medicine versus, or waiting for the critical moments of care to step in.
Right on. Wish more of them would do that, Lowell. So any other questions, comments? If there aren't any, I'm going to kind of summarize our thoughts from today, put that into an email to you all, and maybe we'll come back to this issue again. I think it's something that's important for us to consider. If you have other issues that you'd like to see us talk about, other items, send me an email. Send me a follow-up email and say, we really need to be talking about this as champions for telemedicine across New York State. So with that, unless anybody else has a comment or thought, I would close us out. So I'll give you another second to jump in there. All right. I gave you a second. Again, look forward to seeing you guys next month, talking with you again. We are scheduled, understanding that, vacations often fall in this season. We're scheduled for August 15th at 2 o'clock, and I'll look forward to seeing you all then. Thanks, everyone.
Thank you.
Thank you.
Thanks now.
All right, bye-bye.
Bye now.
Bye.